Dr. Savino, talking about blepharospasm and hemifacial spasm, diagnosis and management.
I had some problem inserting the movies into the slides, so I'm going to have to play them separately. Now, as opposed to what Dr. Lee and Dr. Chavez told you, I'm going to talk to you about something that's not dangerous at all, so that if you miss this, that's perfectly okay. I'm going to talk to you first about blepharospasm. Blepharospasm is a dystonia. What is a dystonia? It's a sustained muscle contraction that is frequently caused by twisting, repetitive movements, or some abnormal posture. And blepharospasm falls under the rubric of a dystonia. Now, one of the things that I've sort of become more fascinated about and frustrated about in seeing patients with blepharospasm, and over the years I've seen many of them, is this issue about an apraxia as well. And apraxia is a very strange type of neurologic phenomenon, strange for an ophthalmologist, where everything works well except the patient can't get it to work. All the muscles work well, but they can't open their eye. It's different than a paralysis, and it's different than blepharospasm, and hopefully I'll show you a little bit about that. And the third term I want you to be familiar with is Meige syndrome, which if you just consider this to be a combination of blepharospasm, which involves the orbicularis oculi muscles and the lower face at the same time, that's Meige syndrome, and I don't think that it has any diagnostic or prognostic difference from blepharospasm itself, and I don't treat these people any differently investigationally. When I see someone who comes in sent in for blepharospasm, you have to make the determination of whether it's primary, which is a neurologic disease, or secondary. Anytime you get eye irritation, no matter what it's from, you'll get increased blinking, and sometimes you'll get spasm. So that you don't have to treat everybody with Botox. Some people you can treat with artificial tears. And the frequency of blepharospasm, which is the neurologic disease, has been estimated at anywhere between 17 to 133 per million. And it is, most people agree, a basal ganglion disease. And there is some genetic problem in a lot of these people. There are some major studies going on sponsored by the NIH in the United States, but not everybody with a genetic predisposition develops the blepharospasm, and that's because you don't have to, because there are modifying factors which are largely environmental. Most of the people that I see with blepharospasm are a little on the older side. It's very difficult, very unusual for me to see a 20-year-old with real benign essential blepharospasm. They're mostly women, and you have to make sure they don't have any anterior segment disease before you make the diagnosis of a neurologic type of blepharospasm. All right, now, here's what blepharospasm can look like. You can just start off with increased blinking, and most of the people start off that way. Then every once in a while, they'll get a sustained closure of the lids, and they can't open it. And then they'll progress into a prolonged recurrent closure of the lids, and then some people actually have a constant closure. I have had people come into my office with one eye closed and holding the other eye open like this. That's how bad their blepharospasm is. And I said, well, how did you get here today? He said, well, I drove. I said, okay, good. All right, let me see if I can...
had some problem with blinking over.
And she was sent to me just because of blinking.
When did this start?
And this has been going on for about a year. And I'll let this run a bit because you'll see that she has almost nothing except constant blinking. But every once in a while, as we continue to talk, you'll see that she'll have a little run of blepharospasm. You see her blinking gets worse and worse as she's sort of being interviewed, and there you saw a little bit of blepharospasm. And what she's telling me, I can hear here, you can't, is that stress aggravates this, and driving aggravates this. And that's typical in this disorder. There are very few, there you go, there's the blepharospasm, all right? So there are very few of these patients who don't have trouble with driving or with stress. Now, let's see, there's one other one I wanted to do here. And this is another patient who's the opposite.
Young lady who came to see me today.
All right? And as I was watching this coming here, I put this up as a form of blepharospasm that was almost constant. And as I watched it, I said that she's got a large component of apraxia of lid opening. Because, and the way I looked at it is, when the brows go down, that's blepharospasm. But you will see that there are times when her eyes are closed when there is no downward movement of the eye, there is no spasm. So she has a combination of blepharospasm and apraxia of lid opening. And I find, and I'll be interested in the panel later to hear what the other people who do this, whether they're the oculoplastics people or the neuro-ophthalmologists, I find apraxia of lid opening to be extraordinarily difficult to treat. And some people say you can give the Botox in a different place. I don't really think you can. And it just doesn't work for me. Now, some people believe that these glasses work. FL41 glasses. And this is what they look like, all right? And what they are, it's a liquid tint that's put on your clear glasses. And there's all of these articles in the literature about how great these glasses are, but they all seem to come from one institution in the Midwest. I'm on the scientific advisory board for the Benign Blepharospasm Foundation in the United States. And we had this meeting with all of these people who are big names in blepharospasm, Howard, Jankovic, Scott, etc., at one end of the table, discussing the science of how these glasses don't work. At the other end of the table were the board members of the Blepharospasm Foundation, all of whom had blepharospasm, and 80% of them had these glasses on and said they worked beautifully for them. So I don't know what to tell you. All I can tell you, it's relatively inexpensive to try if you want to try it. And if it works, it's a great way to do it. It costs $30 for the tint. It may cost you $100 in mail. All right. So light sensitivity is one of those things that make people make people's blepharospasm worse. Dry eyes, most of them are on tears, and obviously any anterior segment problem. And then the genetic factor, we're still looking into that. Now, what about the treatment of this? Botox has become the primary mode of treatment of this disorder. When I was a fellow, Botox didn't exist, and used to hate to see these people come in because there's nothing you could do for them. Most of them were diagnosed as having psychiatric disease, and I had a slew of patients that had electroshock therapy for their psychiatric disease. And in Miami, they did a lot of bilateral extirpation of the facial nerves, and while they may have cured the blepharospasm, it created all their other problems. In 1978, Alan Scott, who's a pediatric ophthalmologist, strabismologist, was looking into using Botox for strabismus, and then he started a trial in 1982 to look into its effect in blepharospasm and hemifacial spasm, and it was a multi-center trial, and I at Wills Eye Hospital was one of the members of that initial trial for blepharospasm and hemifacial spasm. And it was approved by the FDA in 1989, and then people loved it. But then 10 years later, there was a problem with the reformulation, and it became unavailable in the United States. And I had hundreds of very unhappy people on my hands that made the trek up to Canada because they could still get the Botox there. So now there's no problem with getting it, and there are several types that you can get in the United States. I tend to use Botox because I have the most experience with it. And what it does is it just breaks the cycle. And I tell patients, it doesn't cure you. It's like taking an aspirin for a headache. I'm going to relieve your symptoms. And many of them, even though they don't have the spasm anymore, will tell you that they can feel the urge to have the spasm. And that works, and that's the way that works. Now, what's the advantages of the blepharospasm treatment with Botox? It's relatively non-invasive. I have never had a major complication with Botox. The biggest problem I ever have is a hematoma around the eye. It's largely successful. I tell people it works 85% of the time. Not 85% of the people. It works in almost everybody 85% of the time. You can repeat it indefinitely. I had patients when I left Philadelphia that I still was seeing from 1982. And I would inject them every 3 to 4 months. And what I would tell them is if you have a side effect like a little double vision, a little droopy lid, just like the good effects wear off, the bad effects will wear off. The disadvantages, as I already said, it doesn't work all the time in everybody, and it goes away. Now, that's not beneficial to the patient, but it's pretty beneficial to us. Sometimes patients become refractory to treatment, so you have to increase the dose, or you have to send them for another treatment. Now, this is a problem with the orbicularis muscle, and there are these fancy grading systems. And I sort of thought back to 1982. We had one grading system to tell whether this worked or not. You would ask the patient to squeeze their eyes, and you would see how much force it took to open their lid. It was either 1, 2, 3, or 4. And that was the entire grading system. And I still use that because I have patients who come in and say, the injection didn't work. And I say, all right, close your eyes. Now close them, and I can very easily open the lid with no difficulty. The injection worked. But for some reason, the eye is not open. You either have a apraxia lid opening or there's something else going on, but the injection did what it was supposed to do. It knocked out the spasm. All right, so this is the preceptal, pretarsal, and here's parts of the orbicularis, and you want to inject the orbicularis away from where the levator comes in. So this is where you inject, or it's where I inject. People do different places. The important thing is to stay away from the middle of the upper lid. And I also inject the secondary closures. I also inject here around the procerus and around here as well. And I'll usually inject both the brows as well. These are the complications, not terrible. Hematoma is most frequent. Ptosis, if you inject close to the levator, because this stuff diffuses like mad, you'll get some transient ptosis. You get diplopia in some people. The most people that I've seen with diplopia are people who have had blepharoplasties, because their orbital septum is not intact anymore. Some people can get tearing for a variety of reasons, and when I inject for hemifacial spasm, it uncovers the underlying facial weakness that they have, and unless you show them the facial weakness before you inject, they will believe forever that you caused it. This is the one I use, and this is the dose that I start them off with. I start off with a very small dose, 2.5 units in 5 places around the eye. And notice that I put them way out here, away from the levator. I put some up here, 2.5, and 2.5 here as well. That's my minimum dose. And I have carried people for years on this minimum dose. And if I need more, I'll increase it to 5.0 units per site. And I used to say that more than 5.0 units per site did nothing except increase the complication rate. But there was a paper that I believe Neil Miller was involved in. Andy, were you involved in that paper with the super maximal dose? Now, I've had some trouble. The stuff may be out here, but what you want to do is you want to give the same dose that you usually give in similar places, 5 units here, but then in addition to that, it's tough to see on this screen, there are these blue arrows here that come in, and you're going to give additional 2.5 and additional 5. So this is called a super maximal dose, and in a small amount of patients that they had, this had a good effect. They only had 8 patients, but I use it from time to time. Now the last thing is hemifacial spasm. Now hemifacial spasm is an involuntary twitching with one eye closing. It begins usually with a twitching of the lower lid and then spreads to the upper lid and then to the whole side of the face and sometimes down the neck. This persists when the patient sleeps, and what they tell you in the textbooks is you have to do an MRI scan to make sure there's not a cerebropontine angle tumor. I can tell you that I have imaged hundreds of people with hemifacial spasm, and I have never found one structural lesion, but I still do it. And this is what it looks like. All right, this is hemifacial spasm, and you see his face is going, his eye is going, and it just goes constantly. And it's annoying as all get out because it happens during sleep as well. And sorry about the videos, they just didn't insert. So what I do for hemifacial spasm is different. I have never had a patient with hemifacial spasm where the Botox didn't work. Ever had it. And the thing you have to be careful about is not injecting too far down the lower face, otherwise you'll create a complete facial palsy. Patients will bite the inside of their lips, they'll drool, and they'll hate you forever. So I inject around the eye, and I always tell them, I'll get rid of this, I'll try to get rid of a little bit of this, I may even be able to get a little bit rid of this down here, but I want to keep this intact so you still have some tone. So that's the general, I think, what the ophthalmologist needs to know. I didn't cover what you do if your injections don't work in the blepharospasm people. You can send them on for medications. We used to treat, before Botox, we used to treat them with medications all the time. And because there is no one medication that works, I think that it goes to show how poor medications are in this disorder. And then the people who are refractory to everything, we send for surgery with some sort of stripping of the orbicularis. Thank you.